Good evening, everybody, and welcome to the Athletics Ireland Women in Sport Health and Wellbeing Month. This is our last webinar of the series. My name is Anna Grealish, and I am the Women in Sport lead for Athletics Ireland. So I'm delighted to welcome this evening Lorraine Boyce with us, who's going to talk about pelvic floor health, which is something that I think is really important across any level of athletics or sport. How to look after your pelvic floor health. So delighted to have you this evening, Lorraine. If anyone has any questions for Lorraine, you can pop it in the Q&A or the chat box, and I'll read them out at the end. But other than that, I'll hand over to you, Lorraine, and thank you very much.
Thank you very much. I'll just bring up my screen here. Okay, so I hope you can all see the screen here. So tonight's topic is pelvic floor essentials. So we'll be going over a little bit about pelvic floor health, who needs to focus on their pelvic floor health in a few key demographics like postnatal, perimenopause, and menopause. We'll be talking through stress incontinence, prolapse, and a few big topics like that. So just to introduce myself a little bit as well, I'm Lorraine Boyce. I'm down below physio. I'm based in Donegal with my clinic here in Donegal, but I have online services as well. I'm a pelvic health physiotherapist, so I just completely work with pelvic health with pregnancy, postnatal, and pelvic health clients. And I've been doing that now for many years, and it still is a topic, an area of physiotherapy that is just my main passion. So these are a few of the topics now that we'll cover tonight. The importance of pelvic floor health for athletes, especially in postnatal and during midlife. And we'll be talking through two big issues. These are the ones that are most commonly going to affect you, or that I see most commonly coming to me in the clinic. It's not the only issues you might have with pelvic floor, but stress, incontinence, and prolapse are two big ones. So I'm going to cover them. We're going to talk about then pelvic floor exercises, how to do them, and how to know if you're doing them right, how many to do, how long before you see results, things like that. And we'll also talk about what else is there that you can do for your pelvic floor beyond pelvic floor exercises. Sometimes people will do pelvic floor exercises, find that they're not helping. And so if that's the case, if you're coming to this webinar tonight and you think, well, I've been doing my pelvic floor exercises, I'm still leaking, I'm still having symptoms of prolapse, what else is there for me? What are the other strategies? I'm going to talk through some of the options. So I hope that you're going to be nice and clear by the end of it. But if you still have any questions, do pop them into the box and I'll answer them at the end. And I'm happy to take questions afterwards as well. So I will finish up with information on additional resources and support that is out there for you in your own area, and what steps you can take next to take care of your pelvic health. So the first introduction part now is who needs to do pelvic floor exercises and why. And I think that pelvic floor exercises is something that we tend to do when we start to have bother or symptoms with our pelvic floor. When we start to leak, when we have a bulging feeling or heaviness, when we find we have difficulty making it to the toilet in time, we start to think about doing pelvic floor exercises. But I think it's really good to be proactive, to not wait until you are having symptoms. I hope that any of you who don't have symptoms at the moment, by the end of this webinar, you might take a new perspective on being proactive and just doing some pelvic floor exercises to keep things good and to prevent some big pelvic health issues. But also then, if you are having symptoms, it is never too late. And I hope that's what comes across from some of the slides coming up, that even if you have quite moderate severe prolapse, if you are leaking quite severely, using a lot of pads every day, there is still a starting point for you to get your pelvic floor back in a good place and to take control of your pelvic floor health. So I think it's really good to think of pelvic floor as something you should do before you ever have problems. If you're an athlete at the moment and you don't have children yet, sometimes it's easy to think, I'll think about that down the line. Just think early. Can I do something now to start keeping these muscles strong? Very often I see athletes who are training their global muscles. They're training their big leg muscles, their arm muscles, their core. They're doing cardio. They're taking care of their whole body. But they're maybe forgetting about training their pelvic floor to be able to keep up with what they're doing in the rest of their training. So that brings me to the slide of meeting demands. What is what is a good base of pelvic floor strength for one person might not be enough for another. And I think this is where it comes down to with athletes. If someone is in a sedentary job, maybe they are working in a desk-based scenario. They are maybe going for a short walk in the evenings. They do a little bit of swimming or yoga or Pilates, but they're not training intensively. They're not doing, intensive sprinting and running sessions. They're maybe not doing a lot of jump and land activities, high intensity circuits classes, CrossFit, heavy lifts. They're not putting that high intensity load in their pelvic floor. Someone may get away with a weakish, base. There could be some weakness in their pelvic floor muscles, but it's not showing as symptoms because they're not loading their system. Whereas someone else who is really expecting a huge amount of their pelvic floor needs a higher base of strength. So what might actually be okay for one person isn't going to be enough for another. So very often we need to look at the strength training parameters for pelvic floor exercises. This is where, someone doing just some 10-second holds for their pelvic floor and they're finding they're still having leaking on intensive training, but maybe doing some 10-second holds is not enough. Maybe we need to challenge your pelvic floor muscles with more challenging loading strategies. So we're going to talk through how we do that today as well. So let's talk through, first of all, coming from demands. Big time of load on the pelvic floor is during pregnancy and postnatal. So there were actually guidelines brought out about this, how to return to exercise after you've had a baby. And I often have clients coming to me for postnatal checkups at my clinic, and they come in asking me, well, when can I get back into my training? When can I get back running? I feel good. I don't have any symptoms. So does that mean I can go out, start running tomorrow or in 6 weeks? And the postnatal guidelines were brought out, the Return to Running Guidelines 2019. And you can look them up. They are there. If anyone wants the full link to them, let me know afterwards. They were brought out. They were looking at how do we guide women with their pelvic floor health after having a baby? How do we know when it is absolutely safe to get back loading the pelvic floor? One of the things the guidelines said was after having a baby, the pelvic floor is weak and injured in most women, and many women may need instruction and supervision to be able to perform a correct pelvic floor contraction, especially in those women who did not train these muscles before birth. And that brings me to the point, if you can be connected to your pelvic floor muscles before pregnancy, during pregnancy, if you can know, well, this is how it feels to do a pelvic floor squeeze. This is what it should feel like to do that exercise. I have it in routine. I don't, you're not starting from scratch postnatal. You're not starting to do your first pelvic floor squeeze after you've had your baby when the muscles are maybe a little bit swollen or bruised, or you've had a tear and there's stitches, and you're thinking, well, how should it feel in the best of times? Is it is this what it should feel like now? If you have already been doing pelvic floor exercises, you've something to compare it to. So, and I think you've already got the routine set up in place. You're not starting to think, oh, I must remember now to do my pelvic floor exercises when I have a new baby to take care of, my sleep routine's off. It's already part of your day. So I think there's a benefit to doing pelvic floor exercises before you have your baby and during pregnancy. So the guidelines also said seek out a pelvic health assessment with a specialist physiotherapist to evaluate strength, function, and coordination of the pelvic floor muscles, which are often impacted by pregnancy and delivery. So I think the main take-home point here was that there is often a need to get specialist help and assessment with your pelvic floor postnatal. If you are unsure, that's what pelvic floor physios like myself are here for, to help guide your exercises, to assess your strength, to check if you're doing your exercises correctly, and to make sure that they are doing well. Postnatal checkups can be done anytime from generally from 6 weeks onward after you've had your baby. But it could be 2 weeks if you're having severe issues. It could be 10 weeks, could be 6 months. It depends on when you're ready to come in for a postnatal assessment. That's where a postnatal assessment will allow me to look at your pelvic floor if you're happy for me to do a vaginal examination. We can take a history of your symptoms. Are you having any problems? What are your training goals? What were you doing pre-pregnancy exercise? What do you want to get back to? And then it helps to guide that. It's not that when you reach 6 weeks, you get a green light, you are good to go, you are now able to get back running. it's more likely that it's going to be 3 months. So the guidelines have said a low impact exercise timeline within the first 3 months of the postnatal period, followed by a return to running between 3 to 6 months postnatal at the earliest. So the guidelines were recommending to not go out and do running, sprinting, jump and land type skipping, box jump type activities until 3 months, even if you are feeling great. Even if you think, well, I'm not leaking, I have no heaviness, I feel good. There is still healing going on the inside that you can't see. The tissues are soft and stretchier at that time hormonally in the aftermath of pregnancy and delivery. And when you're running and doing impact exercise, there's more give and stretch. And we don't want there to become a problem wasn't there to start with. So they are saying no. Now, that can be very frustrating for someone who is feeling good and their mind, they're ready to get back. Physically, they feel good. They want to get back to their training. And they feel very frustrated being told, well, 3 months. So wait until the 12 weeks at least. But it does say a low impact exercise timeline can be followed. So that can mean that you can do row, ski, bike, provided it's comfortable to sit on the seat of a bike. An indoor bike is great for just building up your training. So row, bike, ski, building up your walking, building up the pace, building up your distance. You can do general conditioning training like squats, lunges, kettlebell training, dumbbell training. You can do swimming. You can do a lot of other activities to still build back up your fitness and your conditioning before just loading the impact back onto your pelvic floor at 3 months. So it's just good to know that. Recommended, it says here as well, recommended baseline and standing for your pelvic floor before resuming high impact, intensity exercise. And they give three little checkpoints. The guidelines that were brought out did go through a list of screening tests to check if you're ready. So basically, before you want to get back to high impact exercise, you want to be able to know, well, can I do 10 fast contractions where I squeeze, let go, squeeze, let go, squeeze, let go? Can I do 8 to 12 repetitions of an 8-second squeeze hold? So that's basically where you're going to squeeze your pelvic floor, hold for about 8 seconds, and you do 8 to 12 of them without the muscles getting tired and fatiguing. And can you do a 1 minute, so a 60-second hold at a low effort level, 30 to 60 seconds, where you're just holding gently in the background and maintaining that squeeze. That's the kind of thing that I can check for my clients here at the clinic, where I can check your technique. I can check, are you hitting those milestones? And then that's a good guideline for resuming high impact activity. You also want to be able to aim to achieve the following without pain, without leaking, without a dragging, heavy feeling. You want to be able to walk for 30 minutes, do single leg balance for 10 seconds, single leg squat for 10 reps. That's the hard one. A lot of ladies struggle with that. It's to do with glute strength and control. Single leg squat, 10 reps without dipping your pelvis or tilting and wobbling. So that's a challenging one and one that's a great aim to get back as well to know that you're ready to load the system with impact. Jogging on the spot for a minute. And if you find that's okay, I would nearly say even if you want to do a high intensity sprint on the spot for a minute, really test it out in a controlled way before you hit your training sessions again, full pelt. Forward bounds basically is just stand, take a squat, and take a big jump and land forward. Do 10 of those. And you want to be able to hop in place for 10 reps on each side without leaking, heaviness, or pain. If you have symptoms with any of those movements, then it means work a little bit more on your pelvic floor, which we'll cover later. And then come back and recheck those. You could recheck those again in 2 weeks' time. You can recheck them in 2 weeks after that and keep rechecking. And when you can do these, symptom-free, you're in a much more confident place to know that you're in a good place to start getting back into impact and high intensity exercise. They also suggest doing things like single leg running man, single leg calf raises, single leg bridge exercises, single leg sit to stand, sideline leg lifts, side plank holds for 20 seconds. All of these are good to check your baseline strength in your glutes, in your core, in your pelvic floor. Now, there's detailed overview of those in the guidelines, and as I said, I can forward the guidelines to anyone who is interested. But it's just to give you an idea that there are screening tests there that can be done, and a pelvic health physio can take you through them step by step to make sure everything is okay. Postnatal checkup. Now, some of you might be thinking, well, I've had my baby 3 years ago. It might be 13 years ago. I am having symptoms. It is never too late to get a postnatal checkup. It might be at 6 weeks. It might be at 6 months. It could be at 6 years or farther down the line. The aim with a postnatal checkup is to treat the current symptoms you have. So if you are having pain where you had your stitches or episiotomy, if you're having leaking issues, if you're struggling with your pelvic floor, then absolutely postnatal checkup and some pelvic health physio sessions will help to address and resolve those issues. But also in the long term, if you've had your baby and you're thinking, well, I feel fine, I don't have any issues, I've recovered well, a postnatal checkup, even just one session, is good to do a check to see what's happening under the surface. Are we missing anything? Is there something happening that is just under the surface weak? Maybe there's a mild prolapse there that you're not aware of symptom-wise, but it's good to pick it up so you can then prevent issues 10 years, 20 years, 30 years down the line. So I think it's good to think of short-term and what the long-term benefits of a postnatal checkup are. Pelvic floor in menopause, and now we're going through these at a good pace here. We're covering the topics fairly quickly, but there's just so much to cover with pelvic floor. So pelvic floor in perimenopause and menopause. I think this is now being addressed a lot more on social media and on the radio and on TV in the last few years, which is brilliant. It never really got much coverage before that. Good to know about what's called the genital urinary syndrome of menopause. Now, I have full training in hormonal health and menopause. So if anyone needs any advice one-to-one, I can go through a full menopause screening for your entire, systemic symptoms like brain fog, anxiety, night sweats, all the big common symptoms of menopause. But what I'm going to focus on here is pelvic floor and menopause. Pelvic floor in perimenopause and menopause is like its own little area. It also has its own version of HRT, which is interesting. So you can have general systemic HRT, and you have HRT cream, which is topical, localized, small microdosage of estrogen, which helps to address these symptoms that are on the screen. So it is like its own little area. So genital urinary syndrome of menopause, it's a bit of a mouthful, and it also, you'll hear it being called vaginal atrophy or atrophic vaginitis. But essentially, it's where the tissues of the vulvar-vaginal area become a bit thin, dry, they can become inflamed and irritated. And that occurs because there is less estrogen in this area. Your body has estrogen receptors all through your system, in your skin, in your organs, but also in your pelvic floor. And when there is less estrogen there to bind with the estrogen receptors, we sometimes see these symptoms starting. I think it's good to be aware of what can be symptoms of this, because very often I have ladies coming into me, maybe they come in with leaking, but when I do a more thorough assessment and I ask them about these things, they're saying, yes, I actually do have a lot of dryness recently, or yes, sex has become uncomfortable, and we start to pick up that they're actually having symptoms that might be related to estrogen deficiency, and then we can start to address it appropriately. So vaginal dryness, vaginal burning, itching, all of those. So anything that's irritated, dry, uncomfortable at the vulvar vaginal area. Increased or unusual vaginal discharge can be one of the symptoms. Burning with urination, your urinary urgency, frequency. So essentially, some symptoms would be similar to overactive bladder, where you feel you need to pee urgently, frequently. Maybe it's a really it's actually quite painful to pass the urine. Recurrent UTIs is a huge one, and it may not be in the early perimenopause that's more of a feature. Definitely, as the years go on, I tend to see it more often. Urinary incontinence. Now, urinary incontinence, we will talk about stress incontinence and the causes of it in a few slides' time, but there can be a hormonal influence. It may not be the only factor. There could be a muscular weakness, maybe a bit of structural prolapse, but also throw in some hormonal deficiency, and it adds to the pattern and the presentation. Sometimes late bleeding can be an issue after intercourse because the tissues are thinner and drier. They don't tolerate the friction of sex as well, and you might notice spotting or bleeding. So discomfort with intercourse, like bleeding afterwards. Decreased vaginal lubrication, so it just feels more uncomfortable. Shortening and tightening of the vaginal canal, so things don't just feel the same. Solutions for this. So pelvic floor function, we want to look at pelvic floor function. We want to assess alongside hormonal deficiency, symptoms related to hormonal deficiency. It is also perimenopause and menopause happens at a time where our muscles are just going to be getting weaker with age anyway. We lose about 15% of muscle fibers in our urethral sphincters and our pelvic floor muscles every decade of life. So our muscles are starting to age and weaken. At the same time, the hormones are starting to get low. That can be a mixed pattern. So I think it's good to look at your pelvic floor function as well. If you're noticing symptoms of dryness, UTIs, get a good pelvic floor screen to make sure everything is doing well. My big thing is treat symptoms early. Don't wait until they are very debilitating. I have ladies coming into me who want to train and exercise and who cannot continue their training because they have such burning and dryness at their pelvic floor, that friction that they have when they're running and exercising, contact pressure on their perineum when they're sitting on saddle of a seat is just it's just unbearable to the point where they can't continue their training. So we don't want it to get to that point. So we want to make sure you're aware of the symptoms and then treat them early. There are a few things you can do. Vaginal moisturizers is one of them. Now, vaginal moisturizers act like moisturizers that you would put on your face. There are specifically designed moisturizers for the vulvar vaginal tissues. They do not have estrogen in them. They are non-hormonal. There are certain brands. You can see the Yes brand there on the top of the corner. Yes brand and a few others are organic, completely organic. They are chemical free. They act like a moisturizer. And also you can see their vaginal lubricants and moisturizers. So let's talk about what the difference in those are. Vaginal lubricants are great for applying if you want to have a bit more glide and comfort for sex. If you're having an internal exam, you can apply a lubrication gel. It provides temporary glide to the tissues and lubrication, but it wears away quickly. It's only applied to the surface. It doesn't absorb in, so it's literally superficial surface gliding medium. Moisturizer is more to do with like absorbing into the tissues and hydrating them and giving them a bit more long-term effect. So over 24 to 48 hours, your moisturizer will be doing its job of keeping the tissues a bit more comfortable. So the same as a moisturizer for your face, you might need to apply it daily, every other day. But just to know that there are vaginal moisturizers and vaginal lubricants. There are lots of brands, but yes, do have some very good products. Always keep an eye out for whatever brand it is that it is organic, there's not chemicals in it. You can get the lubricants over the counter in the chemist, but there are a lot of chemicals. And I'm finding more and more, I'm noticing it in my clinic, that clients are having reactions to them. They're not tolerating the products very well. Bringing me just to the bottom point there of avoid irritants when we're talking about this. Irritants for the pelvic floor and vulvar vaginal tissues could be chemicals that are in lubricating gels, that are in moisturizers. So it's good to look for organic products. Irritants can also be pads and liners for menstrual products or incontinence. I've had a few very interesting clients where one client came into me with leaking and she was using incontinence pads to absorb the leakage through the day, but she was having a lot of burning, itching, and just discomfort, and her tissues were red raw. And I did think that she had some signs of vaginal, atrophic vaginitis. There were signs that her tissues were very low in estrogen, and I did recommend some vaginal estrogen therapy as well. But one thing I suggested to her was to change the product she was using, the pads, to an organic brand that doesn't have plastics in the product and doesn't have scents and chemicals. Even before she got the vaginal estrogen cream, she changed to the organic brand of product, and the burning subsided hugely. The irritation went right down. And she even said her leaking was a little bit less because her tissues were so irritated. It was even contributing into the leaking, interestingly. So I think it's really good to note that there are some very good companies out there who do organic products. We Are Riley and Earth Mother come to mind, but there are a few others. And if you want links or information on them, do contact me afterwards. So avoiding irritants, we very often we're prone to going, I'll get the product that has the scent built in, so it's just masking any scent from any leakage I might have, but it's a little bit counterproductive because it creates so much irritation. Our tissues are less able to tolerate these irritants as we get older. What you might have tolerated fine in your 20s and 30s against those vulvovaginal tissues, they get more and more sensitive and responsive to these chemicals as time goes on. Vaginal estrogen now is And you can see there, one of the brands is Vagifem, there's Ovestin, there's a few different types of vaginal estrogen cream. There are also vaginal estrogen rings you can insert. And basically, vaginal estrogen for the pelvic floor is a locally applied treatment. It is not like the patches, gels, sprays, tablets that you take for systemic HRT to treat your whole system, where it's absorbed through your skin, it goes into your bloodstream, and then it supplies your whole system with estrogen. Vaginal estrogen is very low dose compared to general days application. The way it was described to me once was a year's supply. If you added up all the vaginal estrogen you would apply over an entire year, it's the equivalent nearly to 1 day of estrogen that you would apply through your skin for a HRT. So it is quite low dose, because I know some women maybe who aren't taking HRT are a little bit reluctant to think about a hormonal treatment for the pelvic floor, but it is very, very well tolerated, very low dose. It is so effective, and it can make a huge difference to your pelvic floor health, to the comfort of your pelvic floor for training, for even pumping up the tissues and getting that vascularization and the circulation to your pelvic floor to make sure the tissues are healthy and plump, and that that even helps with training your anal sphincter muscles, your urethral sphincter muscles. And it just means if you do need something like a pessary, the tissues aren't overly dry and thin and tight. They're able to have a bit of stretch and give, and they can tolerate a pessary being inserted. We'll come to pessaries very soon. So when it comes to pelvic floor health, it is never too late to get an appointment with a pelvic health physiotherapist. I have ladies coming into me who are even taking up exercise and in their later years, and they're coming in thinking, well, I want to exercise. The main thing that's stopping me is my pelvic floor, and that's why they're coming to me. So it is excellent to see people taking care of their pelvic health. I also will be having an online pelvic floor exercise group setting up now in June, where it will be online support once or twice a week. We will be doing exercise segments together. There will be video tutorials. That kind of online support is there. If you find that it's motivation that you struggle with, you struggle to remember to do them, to get them done, you're not sure if you're doing them right, there will be group training sessions there. So there are pelvic health physios all through the country. If I can help you, or I can help you find one that is near you. And also you can go through your HSE physio as well. I'll cover your kind of your next steps and your additional resources at the very end. But my main point would be, if you're thinking from looking at the postnatal guidelines I went through, or the slides that are on hormonal health of your pelvic floor, that you're having symptoms, then do absolutely get started now. Stress urinary incontinence now is a big topic. When we think of stress incontinence, we think that it is generally related to weak muscles, that if we're leaking, then the muscles must be weak, and I need to do those typical Kegel squeezes and exercises. But what I would like to just highlight today is that it can be a combined pattern. I want to categorize this now from the start. You may have a muscular issue, that it might be the muscles are weak. It might be that it is a structural issue, that your bladder, if my hand is a bladder and this is the urethra, that the bladder might be prolapsing, or there might be just a lack of support at the bladder neck. The ligaments that are meant to hold the bladder in place inside might be slack due to delivering baby, due to straining over the years with constipation. So you may have a structural ligament issue inside, where the bladder needs more support. You may have a pelvic floor muscle weakness around your urethra, or you may have a bit of both. That's where it gets complicated. So, first line measure might be pelvic floor exercises. If it is 100% a muscular weakness and you have no structural support issue, then doing pelvic floor exercises should resolve your issue. And I'm going to talk through that in a moment. If you have 100%, it is just a structural issue. You've been doing pelvic floor exercises, you've had your guidance, you've done pelvic floor exercises, so you're blue in the face, they have not helped, then I would be suggesting you should be looking at, is there a structural support issue? Is the bladder neck moving? Is the bladder prolapsing? Does that need an internal support? Is that what's needed? Sometimes it's a mixed pattern. There's a bit of both. And someone might need some pelvic floor exercises to boost the pelvic floor muscle strength, but they also might need a pessary support, or some kind of surgery, or something to support the structure inside. So if that is the case and it's a mixed pattern, you do your pelvic floor exercises for 3, 4 months, you think, well, that's relieved 50, 60, 75% of my symptoms, but I cannot get this last bit to go. And that might be where there is an internal support issue. So I think that's good to keep in mind. And we'll go through now a little bit about how we address muscular weakness and what do we do if it's a support issue on the inside. We also want to talk through, when we're talking about incontinence, what muscles are we trying to target? I'm just going to show you here on the model, if you, hopefully you can see this a little bit. We have a big part to our pelvic floor here called levator ani. It's the big outer band of muscles. If we look at the pelvic floor area here as a whole, it's a big muscle that covers the pelvic floor. When we go to strengthen our pelvic floor muscles, and if you go to online, how to do a pelvic floor exercise, you will likely be instructed to squeeze up your pelvic floor muscles as if you're holding in wind, as if you're lifting your pelvic floor muscles up inside. I've had so many clients coming in saying they've been told to do the pelvic floor lift. Imagine you're lifting them up through lifts of a floor, like a lift going up a building, lift it up to floor 1, floor 2, floor 3. So you're focusing on squeezing at the back and lifting up. But actually, that does now target the big band of pelvic floor muscles. What has now come out in more recent months and years in research is that for urinary incontinence, we want to target the urethral sphincter muscles. Think of the urethral sphincter. So think of the urethra, the little tube where the urine in the bladder, so say this is the bladder, the urine comes out. Imagine muscles wrapping around the urethra. They're the muscles that actually we want to target and strengthen to address urinary incontinence. So lifting up and lifting up and lifting up is not actually the way we're going to give those muscles instructions to get them working really well. We may want to work the levator ani more for prolapse, and we'll talk about that when we get to the prolapse segment. But for urethral issues, urinary incontinence, we're looking at working the urethral sphincter muscles. We'll cover spaceries and surgery as well. How do you know if your pelvic floor muscles, the urethral sphincter muscles, these little muscles, are they doing their job well or not? And this is a practical take home you can all do later on yourself. Everyone's going to be doing this later on after the webinar finishes. So the next time that you go to the toilet, that you feel you have a good full bladder, wait until you've got a point where you can say, yeah, I know I really do need to go. Like it's a good full bladder. Sit down in the toilet, start your flow of pee, and count 1, 2, 3, 4, and then try and stop your flow of pee coming out. We want to see now, can you stop it or not? So is it just slowing down? Is there no impact? Once you start that flow, it's going. Can you slow it a bit at least? Can you stop it completely, or does it stop to a little dribble? So can you completely stop it, or is there some flow still going? If you can stop it, how long does it take to stop the flow? When you go 1, 2, 3, 4, and you start to stop your pee, does it take you 3, 4, 5, 6, 7 seconds to get it to stop, or does it stop right away? And then that is a good indicator of your urethral sphincter muscle function. So we're aiming ideally that you can sit down and that no matter how full the bladder is, you can go 1, 2, 3, 4 and stop. And that you can even hold it stop for 1, 2, 3, and then let it go. If you're struggling to do that, or it's slow, or it's not complete, then I would be suggesting work on your urethral sphincter muscles. You can use this as your instruction for your muscles when you're doing your exercise during the day. So when you're trying to strengthen your urethral sphincter muscles, you have incontinence, rather than thinking of squeeze up at the back passage, like I'm holding in wind, lift my muscles up and up and up, don't worry. That I think that complicates it for people. And people come away going, I don't know if I'm doing that right. Am I getting enough lift? Should I be feeling more? Don't worry about what you're feeling with it. Focus more on what is it that I'm doing. If I'm sitting here now and I want to strengthen my urethral sphincter muscles, I'm going to imagine myself on the toilet. I'm going to imagine myself stopping pee coming out. And I'm not making it a real big, vigorous effort. I'm just doing a nice, moderate little effort. And if I can say, I'm imagining I'm doing it, I'm doing the effort, then that's me strengthening my muscles. I'm going to hold that intention to stop my pee for 10, 9, 8, count it down, let the flow go, and repeat. So it simplifies it in that you don't You don't need to worry about, okay, am I feeling a squeezing sensation? Am I feeling a lifting action? Should I be feeling more? I think the biggest, mistakes are that people think they should be feeling a big dramatic sensation, and actually it's very subtle. If you're not sure, practice it a little bit on the toilet. So in the next few days, when you do need to pee, sit down, start your flow, and think, okay, let me see now, what is it I would do if I'm stopping or slowing my flow? Even if it's hard to actually manage it, but what would I do? And then try and replicate that when you're sitting on a seat or standing somewhere in your bed lying down. So that's what you're going to focus on, is the action of stopping your pee. It is okay to do this. I think that's the other thing to clarify. Over the years, there was uh, an idea that, well, don't try and stop your pee mid-flow because it interrupts your pee, it interrupts your bladder pattern, and then it might lead to urinary tract infections. Was the standard advice that pelvic floor physios and doctors and everyone was giving out. But actually, in more recent times, again, all the research studies and all the evidence is saying that was never a thing. There was one little case where someone thought that was the problem, and then it just expanded like wildfire, and everyone was told not to do it. And actually, all the research in both men's health and women's health is saying it's absolutely fine to use this as a test for your strength, and also to use it for training. So to practice what you're meant to be doing, and actually even just to train the muscles to get them stronger. So it's good to know that it is absolutely fine to do that. Additional strategies. Now, I'm going to come more later on about pelvic floor exercises, how many to do and how often, and a lot more about pelvic floor exercises after I've covered a little bit about prolapse as well. So just bear with me and I'll come back to it. When we come to stress incontinence, and I've said now, if someone has a muscular issue, if you do about 3 to 6 months of pelvic floor exercises consistently, so you do maybe 2 sets a day, 3 sets a day, you do that every day for 3 to 6 months, and you know you're doing the right action, you're stopping your pee coming out, maybe you're doing 8, 10 second holds of that every day, twice a day. And you've done that, and that's worked. Brilliant. Job done. If it hasn't worked, I would be thinking maybe it's a support issue inside. That's where you might need a little pessary support. These are little ring pessaries. They come in different styles, like tubes, rings, little closed over pessaries, little dish shaped pessaries, different sizes. And these basically fold to go inside. They squish to go inside through the narrow opening. They expand to fill the space that's there. These, although they look big, are actually very comfortable, and they act like a support, like a scaffold. They go inside and they kind of lift the bladder up into its place. They give it support. They don't allow it to move or drop down. And that's where it's going to address a structural issue. So if you have a weakness of, if you have some prolapse, or even if you don't have symptoms of a prolapse, the bladder neck, where the bladder and urethra meet, might be moving a little bit, even though the whole bladder isn't dropping down. And that's where I found these are brilliant. I had one lady in who had been, before she came to me, she said she came in doing a year, and she'd already done a year of pelvic floor exercises. And when I checked her muscles, there was nothing further I could have advised her. Her muscles were really good, they were strong, but she was soaked to her knees every time she did a cross country run. And so we fitted a pessary for her, and we fitted it, we sent her away. And I said, okay, let me know how you get on. And she came back in saying, I finished the race, and instead of being flooded to my knees, I was dry. For her, it was not a muscular weakness issue, it was a structural support issue, and a pessary gave her immediate relief. Other people, there is a mix. As I said, some people need both. For her, she needed a pessary. I just thought she was a great example of how quickly it can give relief when you get the right pessary. One thing is there are more than one type, there's more than one type of pessary. If a ring hasn't worked for you, if it's fallen out, if it doesn't give you relief, tubes might stay in better. You may need a ring with a little bladder support or a dish to hold in better. There are different styles. You can see in the list on the screen there, electrostimulation. There are little devices, little probes you can insert into the vagina that you switch on, and it delivers electrical impulses so that it strengthens your muscles. It does the work for you as such. There are different parameters on the little device to target different issues with your pelvic floor, and you can insert the probe, turn on the machine, and it will do the programming for you. Again, you need to use it for about 3 months solidly. You can get vaginal probes, anal probes, depending on what your issues are with bladder or bowel. Can be very good if you're struggling to do your pelvic floor exercises for some reason, or you need to boost it. Again, as I said earlier, vaginal weights and electrical stimulation. If someone has done a lot of training, but your demands are high with your exercise, and maybe you need a bit more strength than the average person to match the demands you have, adding vaginal weights or adding a little electrical stimulation parameters to your training could really boost the strength even more. Little vaginal weights go inside the vaginal passageway, and then you can walk around with these in for 10 minutes. They come in different uh, weights, as you can see in the picture there. You can see they come in different weights. They go from lightest up to the heaviest, and you build up through them. It's like using weights for anything else, going to a gym and building up more and more weights as you go. So it does help as well. I think a lot of people buy these weights. They don't know how to use them. They don't know, well, are they suitable for what I have? I think it is good. I'm saying now tonight that they are available, but I think it is good if you're going to use electrical stimulation or vaginal weights to get the advice of a pelvic health physio, even if it's an online session, to find out, are these going to help me? What's the best additional strategy for me to use? How do I actually use them? The more people come into me saying, I had weights, I bought them, I tried them, they fell out. I didn't know what I was meant to be doing or if I was doing it right, so I just put them into the press. And they would be suitable for them. So it's just they need the advice. Support garments are another one that can be used for supporting. So you can see here that there's a little panel. The lanes aren't very clear, but there's lanes built into these support shorts that have thicker material here. And when you pull these on, they are meant to be nice and snug and neatly compressive. So the idea with them is that they actually give a lifting the perineum. They lift your pelvic floor, and the research studies are showing that they actually do lift the organs a little bit. They can lift the bladder neck. So I was saying this is the bladder, the urethra. They can actually come up and lift the perineum and the pelvic floor muscles and actually elevate the bladder neck a little bit, which is actually really interesting new research coming out. And again, they can be good if you cannot tolerate a pessary or you can't get one to suit you or you don't like the idea of these. Support garments would be another good option. Biofeedback, there is a lot of biofeedback devices and gadgets out there. There's a lot of little apps where you put in a probe, you squeeze, and it registers on your phone to show you what you're doing. There's so many additional things you can go to. So don't worry if you are thinking, well, I've done some pelvic floor exercises and they're not working. But maybe just that we need to just tailor the approach. Know that there is so much more than just typical Kegel squeezes. Just covering pelvic organ prolapse briefly here. Just want people to know that you can have a pelvic organ prolapse of your bladder wall, which is called an anterior prolapse, bowel wall, posterior prolapse, or your womb can be coming down, and that's an apical prolapse. Those are the three main prolapses. You can also have the bowel protruding out of the back passage, which is a rectal prolapse. I often have clients come in to me saying, I've been to my doctor, my gynecologist, and I have a prolapse, and I've been told I have a womb prolapse, or they're presuming they have a womb prolapse, and they weren't told any different. And actually, when I check, it's a bladder prolapse or it's a bowel prolapse. And I think it's good for people to know what kind of prolapse they have and to know that it's not always the womb, it can be the bladder, and then that can influence your urinary incontinence as well. These are staged and graded in terms of severity from 1 to 4. There's a stage 1, which is very mild. You may not even be aware of symptoms of that. Stage 2A and 2B are mild still. That would be that you would feel a little bit of a bulge coming down to the vaginal opening. Stage 3 is where it's coming out of the vaginal opening. It's definitely protruding and bulging down. And stage 4 is full, descent of the organ. So it's good to know that, again, if you have any symptoms of heaviness, so what are the signs that you might look out for? Heaviness or a bulging feeling at the vaginal area, low back pain, lower abdominal pain, because of the organ dropping down, it tugs on the ligaments and gives you backache and lower abdominal ache. You might have difficulty emptying the bladder or bowel, or you feel like there's still something there to pass, or you get a wee dribble of urine after you've finished peeing, or difficulty putting in a tampon, or the sex just feels different, it doesn't feel as comfortable, or there's something blocking sex. So, and I think that little picture there just shows you like a normal vaginal opening. Now what's showing there is actually the little dot in the center is the cervix, so that would be a womb prolapse. but also you can get a bulge that might be a bladder or a bowel prolapsing down. It sounds scary, but there is a lot you can do. Now, I'm just going to very briefly go through these. Pelvic floor exercises can help. That is where you might be working more the levator ani muscle. Maybe you have a prolapse and you don't have any urinary incontinence. Your urinary control is fine. Maybe we will get you to squeeze at the back passage as if you're holding in wind, creating a little bit of a lift of the back passage up into the body. So you might be focusing more on doing that kind of just squeeze at the back and lift up. But again, when you're doing that, you're not thinking of lifting up as high as you can and gripping and overdoing the effort. It's still quite subtle. You can use that kind of contraction of the big pelvic floor muscle band, levator ani muscle, to support your pelvic floor when you're coughing, when you're lifting. So when you cough, the pressure comes down and pushes down on the organs, and that's why a cough is actually a test I do to see if somebody has prolapse. So if I get them to cough, we can often see the prolapse. Whereas if I get someone to squeeze their big levator ani muscle, it can prevent and counteract that downward push of pressure. So before you lift, whether it's lifting heavy items at work, lifting kids, lifting grandkids, you're thinking of pre-squeezing up the muscle. Breathing strategy is huge. I'm not going to go into all these in detail, but knowing that whether you're holding your breath to lift, whether you're lifting something heavy and holding your breath, that might reflect as well in weight training. So if you're lifting weights and you have prolapse, get advice from a pelvic health physio about how best to pre-squeeze your muscles, how best to time your breathing strategy. Emptying your bowel. Like I had a lady in who had a prolapse once just from constipation over the years. She had never had children, so it wasn't related to a childbirth injury. She just had spent years with constipation that was never managed, straining and straining and straining, and it had actually stretched the ligaments, and she ended up with quite a significant womb prolapse. So knowing that the constipation is a factor with prolapse and learning how to support your pelvic floor as you're passing a bowel movement can be really good. Again, pelvic health physio can talk you through this in detail. Support garments, as I've covered, you can get these kind of shorts, but you can also get a smaller, neater garment called a V2 supporter, and it's there on the picture. It goes on over your underwear and literally gives a support the perineum, so it's not as warm and as bulky as the big underwear garments. Internal support pessaries, I covered a little bit about them there already. If it's a womb prolapse, you may need a pessary that's covered in the center to be effective. We've had ladies coming in saying that these were fitted and didn't work for them. You may need a different type. And that's where, again, pessaries are complex. If you've tried one and it hasn't worked, there are so many more to try. Surgery can be an option as well for incontinence or prolapse. But all of the gynecologists who I link in with will always refer to physio first and say, try pelvic floor physio. If you try pelvic floor physio and it doesn't work, you can then go down a surgical route, but you've settled your mind that you've tried everything conservative before you go for a surgery, which may have side effects or it's a big procedure and they don't they don't do it lightly. If you still need it, it's there. If you don't, and pelvic floor physio has worked, brilliant. If it hasn't worked, but you still need surgery, all the pelvic floor physio you've done won't be lost to you. You will then be going into a surgery with a strong base of pelvic floor muscles, knowing how to lift well, how to protect and brace for coughing and sneezing, how to empty your bowels well, what garments can you wear after your surgery, getting back to your training. You'll be so tuned in. You are setting yourself up for success after the surgery. After a surgery, I've had clients in who got a surgery who just come into me maybe 10 years after they've had a prolapse surgery. And they're having symptoms again because they had their surgery and thought, that's great. That's that lifted back up and repaired. We don't need to worry about that now. But over time, the same pressures were on the pelvic floor. Their base of strength was weak and it happened again. And they're frustrated that they weren't told this after their surgery to take care of their pelvic floor and to still get pelvic floor physio. So it's good to know surgery is there. I would hold off until you've tried exercises, pressure management strategies, underwear, garments, pessaries. If you still need it, it's there. Absolutely. Some of my clients, it is by the time they get to me, the surgery is needed, but I can at least support their route into surgery. Finishing now very briefly on pelvic floor exercises. So I'm hoping that already, maybe you'll know that if you have urinary incontinence, you're going to focus on your urethral muscles. Focus on the idea of making an effort to stop your pee coming out, hold it 10 seconds, let it go, do 5 to 10 reps of that 2, 3 times a day. If you have maybe urinary incontinence and prolapse, I again would still do maybe that type of urethral sphincter contraction, but we might also get you training that big activation of squeeze and lift at the back passage. If you're not having any symptoms and you're thinking, well, what should I do? Test out, can you stop your flow of pee? That little test we taught. If you're having bother with it, then maybe do focus on your urethral muscles. Other ways you can maybe do a general squeeze at the back passage as if you're lifting it up gently. How do you know if you're doing it right? You'll know if you're doing it right if you can do it and nobody would know you're doing it. If you're doing it and you're lifting your whole body, you're holding your breath, you're squeezing your face, that's way too much effort. It should be subtle and soft. I always say to clients, don't worry as much about what you're feeling in terms of the squeeze. Focus more on the action you're doing, whether it's gently squeezing at the back passage and lifting it up or holding in your pee. Focus on the action you're doing for the 10 seconds. Don't worry as much about, am I feeling the right thing with this? Very often someone is doing a 10-second squeeze. They start in a squeeze, they get to 5, 6 seconds, they're like, am I still feeling that? I don't know, maybe it's gone. Am I still doing it? Very often the feeling of the squeeze fades because the muscles are static. They're not moving, they're not registering movement receptors. So we lose track of the feel of it, but actually the contraction is still there. So that's why I always say focus more on the action of what you're doing than the squeezing sensation. Keep it moderate, always 75, 80% effort. Aim to do something daily. I think doing something daily is brilliant, whether it's once or twice a day, is even that. If you want to get results faster, even 3 times a day, absolutely. But even if you can do it once a day, consistently, it is beneficial. That's what the research is suggesting. If you're starting off now, again, this could be tailored by a pelvic health physio to your own specific needs, but as a general guide, even if you were to do anything from 6 10-second holds, which is about a minute, to 10 10-second holds, which might be closer to 2 minutes. So 1 to 2 minutes, even once or twice a day, would be brilliant. And that becomes more manageable than thinking, oh, I have to do 10 minutes of pelvic floor exercises. I didn't do them yet today. Think of doing them, 1 to 2 minutes, once to twice a day. Aim to do this in maybe sitting or lying to start with. If you're think sitting can be a good starting position to get a feel for what you're doing. People tend to feel better what they're doing when they're sitting on their pelvic floor, especially for the urethral muscles. They can connect in better to what they're doing because they're thinking, it's the same position that I'm on when I'm on the toilet, and I can now imagine I'm on the toilet and I'm holding my pee. But it's also convenient. Sitting tends to be quite convenient instead of having to go and lie down. You may lie down to do them if you have some symptoms of prolapse that are very heavy. Lie down and it takes a bit of the pressure off. How long before I see changes? All the research will suggest it's like training any other muscle group in the body. It will take 3 to 4 months at least to get enough changes that you could look back and go, yeah, okay, this is working or it has worked. If it's very substantial symptoms you've had for a very long time, I'd even sometimes give it to 6 months at least. But I think it's good to know 3 to 4 months at least. I often have clients who do 2 weeks of exercises. They come into me saying, I've done the exercises there before. I did them for 2 weeks. They weren't working, so I stopped. I must not have been doing them right, or they just weren't working for me. But often you're only just laying the groundwork, laying the foundation. It was going to start to give you a buildup of relief. You stopped before you got there. So I think if you were starting now, we are, say, end of May. So think June, July, August, September. Think end of September. When you put it that way, you're suddenly thinking, okay, if I think of working with this now until the end of September, and review your progress. When time you think of that time from now until the end of September as your strengthening phase. If you have symptoms and you want to get to a point where you're symptom free, so you're starting off today, you want to get here. Getting from A to B may take you 4 months, may take you till September. Then once you get there and things are good, you're moving into a maintenance phase. Once a day, once a week might keep the pelvic floor muscle strong, but you're still doing something, but you're moving into more of a less effort, it takes less effort, less time. It's maintaining what you have built up. To get it from A to B takes more effort, input, and time, and then maintaining it is easier. So strength versus maintenance, I think that's good to know. Consistency and reminders are the big one. Set reminders, use alarms on your phone, use post-its, link it to something you're doing. And consistency is so important. And that's why I've actually set up the exercise group as well. So the online exercise group to help with motivation and consistency. Last slide is how will I know if it's working? Measure your baseline, maybe do the little stop the flow test, train your muscles 3 to 4 months, progress your training strategy, add in what you need, stay motivated and consistent, and then retest your measures and make sure has it worked. If it hasn't, at least now you know I might need a pessary, I might need to use stim, I might need to use vaginal weights. I will have that little exercise group online now up and running in June. It's not ready yet, but if you're interested, message me afterwards. It just gives you the expert guidance and the instruction and the accountability weekly. And if you need further help or support with this, contact your GP for HSE referral, contact me for private referrals throughout the country. There's online training courses like what are on my website. You can find me as Down Below Physio on all social media. And you can go to my website to contact me, downbelowphysio.ie, and you can ask me to sign up for the newsletter if you want more info on all of these kinds of topics. And if there are any questions, I can answer them now.
Thank you so much, Lorraine. It's great to have that information around contact, and what I'll do is I'll send that out on the email when I follow up with the recording on this as well. So if people want to share
Perfect.
or contact you separately, they can do that. So much information there, so much
So
information.
much.
I know it is a huge topic, so thank you for kind of covering all the elements that you could in that area. We didn't have that many questions in. I suspect they're probably absorbing the information.
Huge amount of information,
Yeah, huge amount of
exactly.
information. So as I said, I'll be sending out the recording as well. I suppose my first awareness of pelvic health physio was actually after having my children. I was referred to a pelvic health physio, but before that, I didn't know that that was an actual physio
Yeah,
that you could go. But since I've been speaking to many other women who even haven't had children, but they have also kind of found out about pelvic health physio as well. So I think it's definitely a really important area. And through any stage of life, I think it's something that is kind of really useful to even know
yeah,
about and know context. And as you said, there are a lot of pelvic floor specialists throughout the country, but you're going to
yes,
share
yeah,
your contact details to kind of do that. So I will just say thank you for this evening. It's coming up to 9 o'clock, and we didn't have
yes,
any
that's
questions
it.
in yet. But I imagine you could have a few people contacting you outside of this, so
Absolutely.
that's great
I'm
for
happy
doing
to
that.
answer any questions. And if anyone wants to join the training group for motivation or further training, because I know there was so much to fit in, I'm happy to give it the advice and contributions for that.
Yeah, and that actually sounds great. I would say you may get a lot of people taking you up on
Yeah.
that workshop group. So that's great. So thank you everyone who joined on this evening. I hope you found it useful. And as I said, I will share the recording on to everybody so you can listen again and find out more information from Lorraine. So thanks again, Lorraine. Really, really a pleasure to
Thanks for
have you on
having
this
me.
evening. And thanks so much. Okay, good night, everybody.
Good night.